On to our next speaker, Dr. Shivani Dixit, who is working as a cataract and glaucoma consultant and SRJ Netralia Indore. On to you, Dr. Shivani.
Good evening, everyone. Thank you, ma'am, for this opportunity. Am I audible and the screen is visible?
Yes. Yes.
Hello all. I will be sharing a case of phacomorphic glaucoma and the challenges associated with it. Phacomorphic glaucoma is an acute secondary angle closure glaucoma precipitated by an intumescent cataractous lens by its larger size, both equatorially and anterior-posteriorly. Even though definitive management is surgical intervention in these cases, preoperative medical management is of utmost importance. It aims to reduce the intraocular inflammation and intraocular pressure, which will make the cornea clearer for surgical view. In this case, a 64-year-old gentleman who had diminution of vision in left eye since 2 years presented to us when he experienced severe pain in that eye since 2 days. On clinical examination, there was significant corneal edema, shallow anterior chamber, high IOP, intumescent cataract with mid-dilated pupil, suggestive of phacomorphic glaucoma. After starting this patient on topical steroid along with anti-glaucoma medications, the inflammation reduced, the intraocular pressure got controlled, and you can see that the cornea became clearer. Preoperative B scan was normal. The biometry report showed that anterior chamber depth is less, and there is a thicker lens of more than 5 millimeters. Moving on to the surgical management, there are many intraoperative challenges in such cases, starting with attaining a central adequate sized rhexis. We may encounter difficulties due to shallow anterior chamber, and also the possibility of weak zonules has to be kept in mind. Clear corneal side port incision with slow decompression of anterior chamber is done, and after general staining of the anterior capsule, anterior chamber is filled with dispersive, followed by cohesive OVD. Corneal main port with good architecture helps to get better chamber stability during surgery. Before initiating capsular rhexis, the intranenticular pressure is reduced by decompressing with a 26-gauge needle, and the liquefied cortical matter is aspirated. Capsular rhexis is performed using a capsular rhexis forceps. It is important not to let the anterior chamber get shallow and use cohesive OVDs as many times as needed. Here, I started with a smaller rhexis and then continued in a spiral manner to get an adequate sized central rhexis. After minimal hydrodissection, gentle rotation is done to ensure that the nucleus is free in the capsular bag. As you can see that in this case, patient had a hard leathery nucleus underneath intumescent cortex. In such cases, it's difficult to achieve direct shot. I am making a small crater in the nucleus first and then going deep into the substance to get a good hold of the nucleus, performing a horizontal chop to attempt divide the nucleus into two. Due to the leathery nature of the cataract, it gets difficult to get complete separation of the posterior plate. As you can see that I could get a partial chop here. After doing multiple chops of the heminuclei, I could take one nuclear piece out of the capsular bag for phacoemulsification. So after emulsifying one piece of nucleus, we get more space to work around and further nucleus management becomes easier. You can see that there is no residual cortical matter beneath to provide cushion to the posterior capsule. So I have slowed down my parameters while emulsifying these last pieces. This reduces our chances of surge. To add on to the challenges, while injecting IOL, it flipped into reverse position. However, it was flipped back and dialed into the bag. After thorough viscoelastic removal, the case was closed. Postoperatively, the patient did well with a good visual recovery and controlled intraocular pressure. Phacomorphic glaucoma is a preventable condition with timely cataract surgery, but when it happens, a meticulous pre-op medical management helps us get a better surgical outcome. Thank you for watching.
Thanks, Shivani. That was again a very good case. I think we've been having one after the other better and better batting. Excellent. I think this is a clear-cut case when we could think of giving
mannitol. Absolutely. I was about to say the same thing.
And another thing, These are cases probably where you could think of placing a trocar beforehand. So because little pars plana vitrectomy scope is there in these particular cases. So that could also be factored in. And what else? Of course, intumescent cataract, she has discussed it very well and how she would do it. And
it would not be a bad idea to create some space with a bit of a trenching initially.
Yeah.
Just like you rightly said,
Yeah.
because sometimes when in these really hard cataracts with a leathery posterior plate, you find that the amount of lateral separation that you need to do is so much that, the whole bag stretches, the capsule stretches. So if you can create some space there, maybe remove one small wedge of nucleus from somewhere, then the lateral movement gets much more easier. That is one point that I think.
Anything else?
The regarding that spiraling. See, there are in intumescent lenses. If it is leaking liquid cortex, it is okay. But then, if it is the intumescent cortex, which is when you lift up the flap itself, you will see it's bulging up like this, convex. At that point of time, if we continue a rhexis and then move on to the periphery, then the mid periphery again bulges up more. And I am not sure whether it will remain there or it may run away. So if it is bulging up in a convex configuration, I would complete it in a smaller size and then aspirate it off and then fill up the chamber and then continue after cutting the margin of the small rhexis which was created. And they had
very hard cataract.
Yeah, especially and hard cataract.
Axis extension at all. Yeah.
And as I was telling, the nucleus size, I always debulk the center. I make a large trend, go towards the center and debulk. And then when you notice, if you make the initial chop, if you make the chop, it may not go to the center. But then after that, you can go further deep into the already made chop cut and to take the chopper further deep into the chop which has been created, cleavage, and further split. So if you split like that, you need not split drastically till the sides, wide open splits. You can go further more into the split and make small openings so that you don't stress the bag too much.
You call it the multi-level chop.
Multi-level chop. Yeah.
Multi-level chop. I think that covers it. Anything about the post-op regimen in these eyes? You've got the nucleus out and the component of glaucoma bit. Any thoughts on that?
Glaucoma, Sai?
No, I think she was asking Dr. Shivani.
Yes, ma'am. Ma'am, post-operatively, I feel that the first post-op day picture really gives us an idea as to how the IOP is going to behave. I usually, of course, considering the possibility of steroid response, I give more frequent steroids in the initial 1 week, along with topical AGM if the first post-op day IOP is still on the higher side. And then on subsequent follow-ups, we can taper the therapy.
Yes.
Can I add a point?
Yes.
In these intumescent cataracts, the bag will be very loose. So one option is to place the lens inside the bag before removing the last piece. So that will give a support for the bag. So this is very loose. So there is a chance of a capsule being aspirated into the aspiration port.
Yeah, I saw in 1 or 2 of the cases the lens flipping. So see the haptic when it comes out, we have to keep on looking at the tip of the haptic. It should face towards your left always. So when the tip comes out itself, if it is turning to the other side, rotate your hand, and so that the haptic will turn towards the left always, and then turn on. And some haptics which are not the one which the Rainer model one, the straight open ones, sometimes they don't bend and they come straight outside and they bend backwards towards the right like that. So if it is tending to do like that, use your second instrument and fold it off when it comes out itself. You use it, hold it at the tip and push it, it will fold by itself and then you can release. So lens they don't just like that flip. It is our lax way of injecting that it lets it flip on a fast.
Anytime I think the second instrument is not being used properly to guide the lens. But the moment you feel that it's going to split, don't continue with the implantation. Use your second instrument too, so then you can avoid that entire flipping with 2 Sinskey hooks after the whole lens is gone in.
Now we'll have to go get a little faster because we have number of speakers yet, and